Hello again. Welcome to our first full discussion session. The economic case for prevention and embedding prevention in everything the NHS does. And as Andy Burnham was saying there, the core question is how to translate a great service from the 20th century to an even better service for the 21st century, promoting good health, social prescribing and prevention. So let me quickly introduce the panel. David Buck, Senior Fellow at the King's Fund. Professor Matthew Cripps, National Director, NHS RightCare, NHS England, and Duncan Selbie, who will be chairing the session, Chief Executive, Public Health England, and Duncan himself, I've just been learned, has been a candidate for a Great Prevention Award where he just missed being hit by a tram outside. Is that correct, Duncan?
Yeah, it was the weather.
It was the weather. He blames the weather. Over to you.
Thank you. Good morning, everyone. It's fab to be here. We're going to start with, I'm going to put a bit of context, but you've heard from Andy Burnham for those that were here, so I might talk a little bit more about the context, what we mean by health, and the opportunities for prevention. And then David is going to go a bit more deeply about wider determinants, and then Matthew will bring us right back to the NHS and where the opportunities. It will also try and create enough time for questions. So I'd like to, do people see the Times headline today about Britain being the sick man of Europe? Do people see that? What I want to say to you is that that's just simply not the case. I want to begin by talking about the improvements over the last 20 to 30 years in the health of the people, particularly for men, actually, living longer than they've ever lived before. The issue is about a flattening or a slowing down of the rate of length of life. So people are still living longer, but the rate of improvement is slowing down. Now, there's various speculative reasons for that. But I'm more concerned about people that are living, but living in poor health, if you like. So the measure of the measure that we're getting increasingly familiar with about length of life, I think is even more importantly another measure, which is how long you live in good health. And typically, the difference in life expectancy between the affluent and the poor in this country is about 10 years. That's how long people live. But the difference between life in good health and poor health doubles. So the difference in life in good health between people living in Bradford and Guildford is about 20 years. And typically, people aged over 60 will have 2, maybe more, chronic conditions, and a quarter of people will have 3 or more. And yet we know that people are going to be staying in work for longer with the ageing population and the retirement age. If I look at people, who thinks they're in middle age? You've hardly begun. We are going to be working for longer. And the key is about how do we help people to stay well for longer? How do we help people to stay in work in good health for longer? How do we pay attention with more success than we've had about the variation that goes around the country? But I don't want this to be a moment for pessimism, because when we look at health overall, people are living a healthier life today than they ever did. It's just that the rate of life expectancy is flattening, and we've got a bigger problem, which is the life in poor health that many of our people are experiencing. We have the lowest ever prevalence rate for smoking, which is terrific, but it still accounts for half of that difference between people that enjoy good and poor health. So half of the health gap, if you like, is still about tobacco. We've got alcohol admissions into hospital continuing to increase, and liver cancer is the only cancer type that is going in the wrong direction. On the other hand, we've got fabulous improvements in cardiovascular disease outcomes, and lots to be proud of there. But we've still got in England alone about 6 million people living with cardiovascular disease that is in the main amenable to prevention. There are things we can do about this. So to give a sense, I work in Waterloo, Lower Marsh, in around about the sort of just south of the river. And there's a big organisation in Lower Marsh that's got it's like Christian Aid, and it's got a big sign outside that says, "We believe in life before death." Did that work? We believe in life before death. Can we be less focused on the illness and more about how we might prevent it? What are the things we can do to intervene before people become unwell? All right, finally, so when we talk about health, there's a conversation I have. Do we think that the NHS is there, or if you like, the leadership, that's us, of the NHS is there to run a highly efficient and productive outcomes-focused healthcare system? That's a very reasonable belief. Or is it to improve the health of the people? They're not quite the same things. There is a relationship between the health service and good health, and Dave particularly will pick up on that, but it's still quite marginal about length of life and life in good health. And the most important thing that you can offer people to improve their health is to have a decent income. We often talk about the north and the south, and urban and rural, but the principal relationship is between income and outcome, wherever you happen to live. It's about deprivation. It's not about how good we are in the NHS as the principal determinant of how well people are living and how long they're living in good health. It's a contributor, but more important is income. To have a home where you feel safe, where you can afford to turn on the heating, where you're not afraid to go outside. And the importance of being connected in life. So life that has friendship in it, life that has relationships in it. People are familiar with the leader of Newcastle, for those that have heard me say this, talked to me about the importance of love. And I said, steady on. So I'm from north of the border, and that's not really what we do. Well, I say I love everyone, but there's no touching. Is that sense? What we settled on was the importance of affection. The point I'm trying to get across is that we often talk in the health service about isolation in the elderly, but it's about isolation throughout life. And it's not about being soft or asking everyone to hold hands and fall in love with each other. This is a really important determinant of good health. So in sum, there are three factors that affect good health, and there's prevention that can run through all of this. There's the health service and what it itself can do. And there's massive opportunity where the health service itself can make a difference. So cardiovascular disease and focusing on hypertension. Smoking. 1 in 4 hospital beds today is occupied by a smoker. Less than 1 in 13 of those individuals has a conversation with a doctor or a nurse or any healthcare professional about why that might not be a good idea. There are many, many opportunities for the NHS itself to make a difference. But the bigger contribution is about the behaviours that people exhibit, about whether they smoke, drink, eat, whether they ever exercise. And those are choices that everyone's got, but they're wider depending on how wealthy you are, narrower depending on how poor you are. But the single most important determinant of all in improving health and closing the health gap is to have a job. Did you know that having a job is good for your health? Yeah? So I travel by Southern Rail. I was in Oldham last week, and I think Northern Rail were on strike. Is that right? But having a reason to get up in the day, enough money to live on, something meaningful to do, someone to care for and about, are the really important determinants of health. So can we get, that's the context, there's a bit of humility, that the NHS is a huge contributor, big employer, lots it's contributing, there's a lot more it can do, but the humility is about the wider system and remembering that we're part of the solution. We can't of ourselves make the biggest difference. Dave?
Thank you. Thanks, Duncan. Can you hear me okay? Yep. I'm going to stand here because I'm just used to standing at things like this. But I'm going to follow up a little bit around partnership. For those that don't know me, I lead our work at the King's Fund on Public Health and Health Inequalities. And a lot of our work, my work in particular in the last 4 or 5 years, has been around partnerships between the NHS and other sectors, and between the NHS and other sectors and people and communities themselves. Just follow up what Duncan said. We know from the statistics, and it depends on what measure you use, it depends what method you use, but roughly 10 to 20% of our health can be traced back, determined by something like the National Health Service, a publicly funded healthcare system. The first thing to say is that is fantastic. That is amazing. Second thing to say is actually there's a lot more we can do around particularly narrowing variation and inequality in the NHS, and Matthew's going to talk specifically about that. But just hold on to that. That doesn't sound, that's a massive contribution. However, the even more massive contribution is around everything else in our lives and the roles of particular partners with you and with your communities. And I say communities for a quick thing, partly because Bev Taylor just waved at me, who's in the audience. But secondly, and Duncan mentioned this, around things like social prescribing. Now, I think social prescribing, for those of you who haven't heard of it, is a really interesting example of how the partnership between the NHS, and particularly primary care, and the local volunteering sector is starting to develop. It's always been there. It's partly, this has always happened. It's now got a big push from NHS England. There's a fund for this too on NHS England's website, so go and have a look at that, how you can develop local social prescribing examples. But the particular work that I've been involved in the last 3 or 4 years, and there's something coming out soon too on primary care, is volunteering. So it astonished me when we did a piece of work for the Department of Health around the future of volunteering that we didn't actually have very many statistics. We didn't actually know how much volunteering went on in and around the NHS. So we did our own survey, particularly of acute trusts, around the time of the Olympics. And if you remember from the Olympics, one of the big, great stories about that was the games makers. There were 78,000 or so games makers. So what we discovered was that every single day in your NHS, there's at least that amount of volunteering going on, which was not celebrated at that time. We also know from some subsequent work, 1.6 million people volunteer in some formal way with the NHS, offering formal, regular hours, which is astonishing. But the even more astonishing thing is 6 or 7 million people said they would love to volunteer in the NHS, to give time back to support the NHS, but they feel ill. They're not able to do so because of their illness. So I think one of the challenges and one of the great opportunities for the NHS and for you is how do you work with people who are ill, who want to give time back? How do you make it easier for them to support you in your roles? So I'll leave you with that thought. I could go through a long list, and I will do, of partners for the NHS for work that we've done. You'll be glad to know I won't go into great detail about all of that work, but it's struck me just how powerful local authorities are and how important they are as partners, particularly across the wider determinants of health, but specifically district councils. Who knows what district councils do? Nobody, no one's speaking. Yes. All sorts of things, that's absolutely right. So they cover about 60% of the area of England and about 40% of the population. You're absolutely right, they're responsible for things like green space, for economic development, for homelessness, supporting homeless. A lot of work engaging with communities, coming back to the communities issue. So you have partners out there that actually many people in the NHS currently aren't, I'm not saying you're not, but currently aren't engaging with. They do things obviously like environmental health protection, keep the rats away from the doors, literally. So we are astonished about just how powerful those partnerships could be, as well as with county councils and with upper tier authorities. We've also done some work on housing and health, particularly with housing associations. Housing associations are doing some marvellous things in partnership with the NHS. I won't go into detail, but there's an absolutely astonishing both actuality and potential to do more between the NHS and housing associations. There's more, and particularly through the SDP process, and as that goes forward, that we think could be done with housing in particular. There are some great examples in SDPs in housing, but there are not that many. So there's a challenge there for you and for housing providers, be they housing associations or local authorities. But I want to move on to, I guess, the NHS as a wider determinant of health itself. One of the criticisms, and I think valid criticisms of the public health community, is that we tend to get stuck into various boxes. We've either got the wider determinants of health over here, we've got lifestyles over here, and to some extent we've got the contribution of services over here. Now we all know as people, not necessarily as experts, but as people, that those three things all interconnect. And I'm really keen to strengthen both the recognition of the role of the NHS as a wider determinant of health itself in all of your communities. If the NHS wasn't here as a thought experiment, if we had to purchase healthcare ourselves, income inequalities in this country, which are already some of the widest income inequalities in the developed world, which we know is bad for our health, population's health, would be 15% wider than they are. The NHS, by virtue of its existence, doesn't matter whether it's producing TV sets, treatments, healthcare treatments, whatever, is a massive wide determinant of health in all of our communities. And I don't think that we recognise that enough. You don't, I'm sure some of you do, but the NHS doesn't recognise the power it has in its own communities. Every pound that is spent for treatment could have, the same pound could do something for prevention, and does, and the same pound could do something for the wider determinants of health. There are fantastic examples across the NHS as ever where that is happening in terms of bringing in people from more deprived populations as apprentices, etc. Lots and lots of examples. But as a whole, I think the NHS needs to be, and you need to be, both understand your contribution to the wider determinants of health, celebrate it, shout about it, talk to your partners about it in your local economies, getting back to Duncan's point about having a good job, and frankly also to be challenged a bit more on this. We know from work from the Joseph Rowntree Foundation and the Centre of Health Economics that about 20%, the excess cost to the NHS, to the budget, of poverty is about 20% of the current budget, 25 billion pounds. That's huge, but actually the NHS is part of the solution as well as actually having to mop up the consequences of that, I think. So the poorer parts of the country you're in, the bigger proportion as an economic entity the NHS is. That is a massive opportunity. So I guess I would leave you just to saying, maybe if one thing you thought about after going away from hearing me today is think about what is the opportunity in your community, in your role, to maximise your economic impact in your local place, because that will improve health through the wider determinants of health. Thanks very much.
I'm going to stand here as well, partly because this is a psychological crutch and partly because if I hold my notes up, you'll see how much I have the shakes. We know that there is overuse and underuse in every single local health economy in England. And we know that overuse is wasteful and that underuse leads to health inequalities. And health inequalities leads to unnecessary exacerbation, which leads to overuse, which leads to more waste. And so the cycle continues. So an example of variation is that you're twice as likely to successfully quit smoking when you're helped by the NHS in Northumberland than you are when you're helped by the NHS in Lincolnshire. And yet Northumberland and Lincolnshire are demographically very, very similar. So the question is, can that possibly be warranted variation? We also know that the manifestation of unwarranted variation in the system is too much activity in secondary care and not enough in primary and secondary prevention. And other things we know include that better detection and prevention of, for instance, atrial fibrillation
would lead to 5,000 less strokes over 5 years, and that would save £191 million in health and social care spend. We also know that better detection and prevention of falls would lead to 25% reduction in those falls, and if everybody achieved the 75th percentile performance amongst their demographic peers, then that would save £59 million in emergency admissions alone. We also know that there are around 5 million people with pre-diabetes, and adoption of the diabetes prevention programme will reduce that conversion rate to actual diabetes by 26%. But the challenge is in the rate of return of this improvement. We tend to say invest to save, but what we really mean is invest in long-term sustainable population health and well-being, and if at a system level we use the principles of financial phasing, and at an STP level we work together to reallocate capacity from where it is currently employed delivering activity that the variation shows is unwarranted, we can make this happen. An excellent example is the Bradford Healthy Hearts programme, which is the prototype for the RightCare CVD prevention optimal pathway. In their first year of implementation, they combined delivery of a quick win, a medium-term win, and a longer-term win. The quick win was via statin switches, and they achieved 6,000 statin switches in 3 months. And not only did that improve population healthcare, it also got the cash flowing. For the medium-term win, they focused on improvement in hypertension management. And for the longer-term win that they implemented at the same time, they focused on stroke prevention reform, and as a result have achieved 38,000 more people remotely monitoring their blood pressure. That collective delivered 210 less deaths from stroke and MI in the very first year of implementation. And just avoiding those deaths saved more than £1.6 million in a medium-sized health economy. So by doing things like this in local health economies and then spreading that across the country, and by working together to reallocate resources from overuse to underuse, we can all do this. I'll hand over to you, Duncan.
Thank you. Thank you. So this is working again. So Public Health England has shared with STP leaders and quite widely the evidence. It's all nice, approved. Here are 6 things that if you were to work on locally, you could improve outcomes, reduce demand and save money. They're actually very simple things. I gave one example about smokers that are in hospital. This is not so much about asking people to not smoke outside a hospital, but it's more acceptable to smoke outside a hospital these days than it is to smoke outside a pub. And there's just something we should be bothered about that. But what I'm really bothered about are the 1 in 4 people that are in a hospital bed that no one's having a conversation with, which costs nothing but to refer them to a stop smoking service. If you combine the most effective way of quitting, which is accessing a stop smoking service, with the most popular, which is to use an e-cigarette, then you can increase your chances of never smoking again 6-fold. It's like staring us in the face, and there's 500,000 admissions every year because of tobacco-related illness, and for every person who dies early, another 20 are ill. So here's a cracker, right? And then there's 2 in alcohol, one that's in primary care, about assessing people, getting them into some form of support, and then there's support when you're in hospital. So when I was responsible for Brighton and Sussex University hospitals, we had hundreds of young people that came in an evening paralytic. They were paralytic before they went out, and they were even whatever the worst is than that when they came in. Our job as a hospital was to rehydrate them. The thing that bothered me the most was the ones that said their mate had had a fall and we had to wait until the morning so we could x-ray the neck. This played havoc with the emergency room. I never had a conversation about why. Today, I take a photograph and send it to their mum. And then there's action that could be taken on blood pressure, hypertension, the silent killer. I mean, it is such an amazing opportunity. If we could increase the number of people that we know have hypertension and did something about it, a statin or something like that, we could absolutely knock thousands of admissions out for stroke and heart attacks. Remember when the NHS used to be surprised by winter? Remember those days? John Reid said to me when he was first started as a health secretary, and I was the chief botherer of the NHS in those days, if any of you remember, and he said, do you mean the NHS is surprised by winter? I said, yeah, every year. But actually today, half of strokes and almost as many heart attacks come as a surprise, because we don't know a simple thing like, you know, what's our blood pressure. Matthew was talking, or Dave might have been talking about frail elderly and avoiding falls, or long-acting contraceptive. You know, there are half a dozen measures. They are all completely easy to do. The point is, not everybody does them. And there's a whole lot of reasons for that, not least how busy everybody is, and about how do you prioritize this sort of thing. But we don't have to be looking for the next. We don't have to be searching for an answer. It's like right in front of us. So what we were seeking to do was put it in a bit of context. But this is about the NHS. We're a huge supporter of what Matthew's doing in RightCare and about getting the evidence out to people, not hectoring, just saying, here's how you're doing, here's how others are doing. There may be something in there for you to learn from. There you go. That's what I meant to say first time round. Could we have questions? Yes, gentleman at the front. Are you just going to shout?
I know there's a lady.
There's a lady coming.
Hello, I'm just lady behind you. We can hear you.
Yeah.
So we can repeat the question.
I'm Tony Johnson. I'm a governor of Selbie, and I'm a health I'm concerned about housing because all we're seeing is new housing estates, 3, 4, 5 over the mountain, whereas what we want is a concentration almost exclusively on older people, and so that the existing housing can be released. And on those, I want substantial sites where there are health and social care facilities there, community facilities, so you deal with social isolation, can actually help people not to go into hospital so quickly and get them out more quickly. And I'd like to see not needing to go to care homes to the extent that they do because they can remain on their own.
So the questions, gentleman at the front, the governor in Stepping Hill Hospital, is a big question about housing and about the ageing population and how we could help people stay in their own homes for longer and not have to go into statutory care. And I think also the biggest shift in the last 20 years in housing, improvements in housing, has been in social care housing, sort of local government, housing associations, but we've not seen anything like that improvement in private sector rented. And then as the ageing population, new development. And finally, the point that we could make further progress by working with existing housing, because where people are living now, as well as, of course, be concerned with new build. Dave, did you want to?
Well, I completely agree about that. I guess to give some sense of some good practice. So I did mention our work, particularly with housing associations. So to be honest, I've not done so much work with local authority build themselves, but there are some fantastic housing associations working closely with the NHS and with local authorities, looking at how they can support people to live longer and more independently in their homes. And that's both physically in terms of changing the nature of the housing, but also much more support for people in that housing. So I would urge you just to look at either National Housing Federation website or our website to look at that. There's also, obviously, we had Malcolm Grant on earlier, obviously a real champion for the Healthy New Towns programme. So they are piloting some of that innovation that you are looking for, and I think what's come out of that was, to be honest, it was quite a small piece, I wouldn't say it was a throwaway line in the NHS 5-year plan, but a relatively small focus in the 5-year plan, and what's come out of that is a huge interest from local areas trying to learn from that, so they're trying to scale that up. One of the challenges I think we have is healthy new towns. What about healthy old towns? Yeah. Most towns are old, and as Duncan says, our housing stock has improved dramatically in the social housing sector, but we know that's been falling. Yeah. I think the challenges are for the private rented, in particular, in large urban conurbations like this, and also in London. One good piece of news in London, I guess, and again comes back to the role of the mayor, is that recently, I think the last week or two, the London mayor has said no to a developer saying, I want to reduce the proportion of social housing. He said, on a development, he said, that development is going to be 100% social housing. So I think there is a stronger political appetite across the various partners to recognise the problem. That isn't the answer to the problem, but there is some good practice out there. The other thing for me is some really interesting, I will finish in a minute, some really interesting trials going on around the country, bringing the generations together. So we know, actually, we haven't got a shortage of housing, we've just got, it's distributed unequally where it's needed. And so there are some really fascinating trials where older people who are isolated are living and connecting more with younger people who can't afford housing, and there are spare spaces. Obviously, trust is really important of that, so the role of intermediaries like Age UK, etc., are really critical. But actually, bringing the generations together, I think is really, and which has broader consequences and positives.
Thank you, Dave. I'm going to come to the lady at the front.
Hi, my name's Marsha. I've got both physical and mental health problems, and I recently spoke at the King's Fund on comorbidities in mental health. Now, I take 30 tablets a day, and they all have contradictions to each other. And I have fibromyalgia, which is an awful debilitating pain condition. Now, as that gentleman said about older people housing, but there's no adapted housing for me. I'm 41. We need to consider that as well, because it's over 55s, etc. And when I contact the council to ask if they could put in a walk-in shower to my council house, I'm told no, that they'll move me elsewhere. But I have roots and everything there and the stability. So that we need to really rethink everything, and it would cost less money and less by actually putting in a wet room for me. One of the things about population plan is keeping people in their communities instead of moving them.
So people living in places are not conditions and diseases. They're not driven by institutions, professions, or, it's not about disease burden, but about you and where you're living and how and what matters to you in your life. And David's point about social prescribing is at the heart of saying it's also economically very sensible. It is the economics of prevention to keep people as well as is possible where they are, as comfortable as they can be, and what matters to you and how you can live the life that you most want to live and how we can support you in that. We can't define you by a medical condition. And I'd love to know more about that conversation that you've been having locally, but we could talk about that separately. You're making a much broader point as well about the economics of prevention. And my earlier point I was trying to make is that this affects everybody throughout life. This is not just about being old, but about all of life. Matthew?
They're both connected points, obviously, and just to go back to the right to the other age range of the ones you were referring to. 2 of my 3 children were born in your hospital, so I have a very warm place for you. But there's clearly a correlation, as Duncan's alluding to, between quality and use of housing stock and variation therein, and variation in healthcare. And we're in discussion with Greater Manchester on trying to prototype some kind of combined health and housing variation data to try and pull that out, because then that allows for people to identify where that variation is in their health, local economies, health and social care economies, and then we can move on to the next stage of improvement, which is, well, now we know where the variation is and which bits are unwarranted. What would it look like if it wasn't there, and can we deliver that? So I completely agree, and we are moving in that direction.
We are. It's to show the direct connection between a poorly heated or damp home and admission into hospital. I mean,
we all know it. We've just got to draw it out.
And so the costs are being incurred. The trick is about, if you make the investment, who gets the benefit, and that's why the system has to come together, and why we're keen on sustainability transformation plans being a big enough scale to say, actually, we can pay attention to this sort of thing, because we know it will help, as well as the individual, of course. Lady over here, standing up. Did we have any other questions? To get a sense of at the back? Okay, thank you.
Hi, I am Shalini. I'm Principal Secretary Health, Government of Karnataka from India.
Hello.
I liked your sentence, it's life before death, and that for if you have a job, you have greater chances of having good health and good mental health as well. In that context, since we're talking of prevention, I would like to know if the King's Fund think tank would like to explore the preventive aspects which are proven in terms of control of NCDs or mental health or general immunity through yoga and Ayurveda. I have great clinical evidence to show that how the diabetes can be won over, cancer can be won over, and many more, and more especially the mental health. So I extend that to you. Thank you.
Thank
That's
you.
one for you, Dave.
That's one for me, isn't it? Happy to have a conversation, particularly around mental health and resilience, and we know some of the benefits for that. So happy to have a conversation afterwards. Thank you for coming, by the way.
Public Health England has a whole range of relationships in India, and we're very glad of those. There's much to learn from each other. I'm going to, at the back, who was it that said? Yes, thank you.
Hi, Arif from Blackpool. Don't disagree with anything you've said, but I just wondered if the focus is too adult-focused and we're missing the whole children and young people's piece. I mean, in terms of prevention, if we reduce obesity, breastfeed our kids, make sure their speech and language is appropriate and they've got appropriate school readiness, and are emotionally attached to their parent or caregiver, I think in the longer term that's going to reap us bigger rewards, and I see that missing from the NHS plans currently.
So Arif, can I honour the work going on in Blackpool, which by any measure, you face many of the most difficult health profiles in the country. Here is the 2-minute public health lesson about what matters, okay? If you know this, you don't have to go to Harvard, okay? The single most important thing you can do for a child is to get them ready for school at age 5. School readiness at age 5 will tell you pretty much everything you need to know about the future prospects of that child. By the time they get to age 11, if they have Key Stage 2 reading, at a population level, they will do fine, A to C or whatever it is these days, at GCSE. Okay? If you don't have Key Stage 2 reading at age 11, your chances of doing well at GCSE drop to 1 in 10. It drops by 90%. But you know it at age 5. So what Arif is talking about what we do, and the NHS has got a big contribution to this, but but it's part of a wider range of things, is the single most important metric. And I think Andy Burnham spoke about this, about school readiness is what's going to drive early years for Greater Manchester. The second most important thing is young people to have something to do as they become an adult. So in local government, that's talked about not in education, employment or training. NEETs, people heard of that? It's intuitive, but a young person having something to do, enough money to live on, a reason for getting up in the day, becoming an adult. And the third and final measure is to have a job. Economic prosperity, equality of prosperity, creating jobs that people can get. Arif, there's no point putting a high-value employer into Blackpool and expecting local people to pick up the majority of jobs. You have to create work that people can get as you improve the education system and you improve the housing offer and you improve the range of ways in which people can engage in society, which is what I know Blackpool is doing. So creating jobs that people can get, economic prosperity, money in their pockets. So it is a wider determinant thing, but as the whole system, recognising that our part to play in young children being ready, not through the lens of a health visitor, but through the lens of a teacher. Does that child know how to sit? Does that child know how to ask for help? Does that child know how to play? Does that child know how to go to the bathroom? Does that child know how to hold a knife and a fork? These are the basics about what a child needs to be able to do, and it matters to the entire life that they have before them. So Arif, keep the revolution going, you know, never give up.
Just a quick reflection. So, very good challenge. And to be honest, my institution, we've recognised that actually our work on children has taken a back step, is not as obvious as our work, particularly on older people. Neither is our work on working age populations either, to be honest. So we are sort of seeking to, we've brought our material together into one place, on the website at least, and seeking to think about what we can do. The other thing to say, I guess, on children, is I think there's also some really great news about children too. So compared to when I was young, children as a whole are not experimenting anywhere near as much with alcohol or tobacco. Physical activity is a major issue for children. It's probably got worse since I was younger. But there are some really positive trends in our population which we do not understand enough. So we have to understand the positives as well as the challenges and then try and learn from that. But also an area where we know there are real challenges is around mental health of children, particularly young girls. And I hope that the Green Paper, which has been flagged, I think it's still coming, I hope it's still coming, will say something about that. And the other final thing to say is, supporting Duncan, is that it's a critical role of schools. We did some work some time ago around multiple behaviours or how behaviours cluster in the population, because 7 in 10 of you, and this would include me, these two are paragons of virtue, but of us don't adhere to government guidelines on at least 2 health behaviours.
It's cool. Right.
And we know that's really bad for your health. And we know that's the same for kids too. Yeah. So schools, really strong, supportive, particularly emotional resilience at school, we know is protective of developing risky lifestyle behaviours in children. So the role of the school environment, of course the role of parents too, but is really, really critical. So just to reinforce that point, it's not all about the NHS.
So of those 4 behaviours, do you drink? How much? Do you smoke ever? What do you eat? And do you ever exercise? If you're in your middle age and you take action in 1 or 2 of those, you'll double your chances of being in good health at 70. I can give you individual pension planning on the basis of those risks. See me afterwards.
I'm going to see him afterwards.
Now, I can, in the middle of the room, is there anyone that wanted to ask anything? And then here, yes, gentleman at the front.
Just thinking of your time. So you've got to be
okay, thank you. Thank you. Just at the front? I'm afraid this will have to be the last question. Sorry for that. Do we have a microphone?
Has anyone got...
So could you stand up and shout?
So, Prof Newton, NHS England, is there an economic case for prevention even if it doesn't save us money?
Yes, and it does. So the literature is very clear about this. And there's often a challenge that, if we do this sort of thing, doesn't that just cost the country more over time? That is comprehensively not the case. There are, of course, other reasons why you want to do this sort of thing. And, being in good health means, particularly as you age, that you can still be there for your grandchildren. That's quite an important factor affecting. But the literature is clear. I can say as well, in economic terms, that as the population ages and as the population stays working, so think about 65 becomes 66 becomes 67, for every 8 months that people remain in the workforce, you increase GDP by 1%. You increase GDP, wealth of the nation increases by 1% for every 8 months. That's quite an untapped potential for how we fund this sort of thing, looking into. So for those that I was saying were thinking about they might be retiring at some stage in the future, please know that you'll probably be working for a long time to come. Matthew, last word, and then
I'll just
Dave.
go back to that point. I think a healthier workforce is a more productive economy. So even if you took out focusing on the individual and the population healthcare, what we're trying to do makes sense.
Dave?
I would say yes, sometimes, but not always. But I think saving money, I say, is not. I guess the parallel is we don't do heart transplants to save money. We do them because we do them to improve health. So I think the test for prevention should be the same test as it is for treatment, which is cost effectiveness. We've run ourselves a little bit toward, and I think it's very valuable to have return on investment information, but I would say let's not, and I'm a health economist by background, I would say let's not kid ourselves that everything is going to be developed a return on investment, but neither should it, because it's got to be, the first test is cost effectiveness, and that should be across prevention and treatment. The second thing to say is that actually there's value to delaying expenditure too. So actually prevention can often delay expenditure because people are healthier, because people are living longer. But we, unfortunately, I hope it's not news to you, but we all have to die sometime. So we will always rely on a well-funded and supportive and powerful NHS.
Yeah.
But we should do prevention, and there's far more cost-effective prevention out there than we currently do. We don't do it systematically, and we don't do it at scale. That's the challenge for us.
So thank you, Dave. Thank you, Matthew. Thank you, everyone. And enjoy the rest of the day. Thank you. Thank you. Brilliant.